We'll now hear from our third panel, sharing examples and experiences related to STI prevention and control at the state and local levels. As a reminder, same thing, like speakers to remain seated until their presentation. For Q&A, we'll have the entire panel at the table up front to take questions from the committee. Okay. And then we'll have the entire panel up at the end. And we have one panelist joining us remotely, and that person will be introduced in a moment. So in this panel, we have 10 minutes per speaker and 20 minutes for Q&A, and there are four speakers. First of all, Dr. Leandro Mena, who is the STD Medical Director at Mississippi State Department of Health and also professor at the University of Mississippi Medical Center.
Good afternoon, everybody, and thank you to the committee for the invitation to be here to share our experience. What I will share with you is pretty much the result of a group of individuals, of the work of a group of individuals that with a bit of ingenuity have recognized a need, are aware of the urgency to act, and recognize that STI control is not the responsibility of a single agency or organization, but of everyone, the community at large. And when I say community at large, involving, I include the consumers, who are the recipients of our interventions. We're very lucky in Mississippi to have a leadership in our state health department, community-based organizations like My Brother's Keeper, and the University of Mississippi Medical Center, the Division of Infectious Diseases, and now the School of Population Health, a group of individuals that recognize that while not a single organization has the capacity to address the STIs and HIV prevention needs of our population, there is a great opportunity to partner, collaborate, and just support each other in the benefit of our most vulnerable populations disproportionately affected by these epidemics. While recent years' decrease in public health funding has negatively impacted local health department capacity to provide STI screening and treatment services, in Mississippi we have been able to leverage our community, public, academic, and private partnerships to attract grant funding and share existing resources to build a network of clinics that provide access to affordable, confidential, affirming sexual health services to our most vulnerable populations. We have a network of clinics that currently serve a combined over 10,000 patients per year, 75 to 80% of which are Black, more than half are uninsured, and have an income below $10,000 per year. I don't have to mention to any of you that Mississippi is a state where Medicare was not expanded. Therefore, a significant proportion of the population that we see are uninsured will have been benefit from that. And that, I think, is an important first barrier to any kind of long-lasting modification that we can provide to our health systems. Going back to the clinics, these clinics are the 5 Points Clinic, which is our public funded traditional STD clinic that offers free testing and management of STIs. The clinic, primarily refers patients for PrEP, PEP, and HIV. We also have Express Personal Health, which is a clinic at the University of Mississippi Medical Center that offers fast and confidential testing only services. It's a walk-in or same-day appointment clinic that provides a visit that guarantees a visit duration of less than 30 minutes. Free chlamydia, gonorrhea testing that is done through self-collected swabs, syphilis screening, HIV, Hep C, and Hep B screening. This is a clinic operated by nurses, and there is not a clinician on site, and provides a screening for mental health, alcohol, and substance abuse, and other health behavior assessments with referrals. We give same-day ART for those individuals who are diagnosed with HIV infection, same-day PrEP, and of course post-exposure prophylaxis, which is done as soon as the need is identified. This model is one of that. This model is one that will be soon replicated in a soon-to-open teen health clinic in Jackson, and new multidisciplinary LGBT health clinic at the University of Mississippi Medical Center, and in an ASO in the Mississippi Delta. The third clinic is Open Arms Healthcare Center. It's an LGBT primary care clinic owned by a community-based organization which offers visit called Becoming a Healthy You, which is a free comprehensive health assessment that checks the BMI, blood pressure, glucose, cholesterol, chlamydia and gonorrhea, syphilis, Hep C, Hep B, HIV, and other health risk behaviors. This screening service is also offered at community-based organizations in the Jackson metro area, Hattiesburg, and Gulfport. Open Arms was in every aspect designed by the community, from the name, the location, services provided, logo, etc. In all these places, we have made a concerted effort to provide the staff with annual LGBT cultural competency training. Also, upon hiring, all the staff is required to do these modules, and we have really treated the LGBT cultural competency training the same way that we treated HIPAA training in the late 1990s, early 2000s. Every year is done. Every time a violation is found, we have very little tolerability. Retraining of all the staff is encouraged and is done in most of these clinics. Additional training of caring for transgender and gender non-conforming individuals is actually provided on an annual basis. STI treatment and management is provided with the staff, so there is a significant component of education and capacity building for the staff. And in the past 2 years, we have added trauma-informed care, recognizing the very traumatic experience that our patient population has. Some of the evidence-informed or evidence-based initiatives that we have implemented in these clinics include, beyond adopting a sexual health as a part of an overall health framework, include the provision of a really sex-positive and affirming health services. A lot of this has been discussed today, but I really can underscore the importance of this, especially in communities and socially conservative, where sex is often not what you speak about or with, even with your sexual partners or friends. And often people lack access to reliable information to address their sexual health concerns. We have adopted a no-tolerance policy for discriminatory behaviors in our clinics. I think it's really important, if we're going to address sexual health prevention needs of our country, to really, promote a shift of cultural norms where sexual health and access and utilization of STI screening services are normalized. And along with this, I would like to make a plea for age-appropriate evidence-based sexual health education in schools. In spite of all the evidence of the effectiveness of abstinence-only programs, abstinence-only programs are very often the only sexual health education available in our schools. Integration of sexual health with primary care and other health services such as HIV care and transgender care is one of the things that we have done, especially in our primary care clinics. And evidence of the success was about 2 or 3 years ago. One of the managers of Open Arms of the primary care clinic came to me and said, "Hey, Doc, when are we going to start seeing people with cough, general health problems?" I said, "We've been doing that. We just happen to do STDs screening every person who walks in." So for them, it was difficult to recognize the difference between one and the other. But that was, I think, the evidence that really, we're able to achieve full integration of sexual health in primary care. All MSM who come to our clinic are offered chlamydia, gonorrhea, extragenital screening regardless of reported exposure, unless refusal, or at least in the first visit. And I have to mention that this extragenital gonorrhea and chlamydia screening has been really possible because of the support of the health department. Think about this. Health departments have limited capacity to offer clinical services, and they have really very wisely used some of the STD prevention money to fund the testing in clinics that are not necessarily health department clinics funded. In exchange, we have a very close collaboration, and very often disease intervention specialists are called on site to see our patients when they are diagnosed with reportable STDs, including HIV, of course, but syphilis and in some cases gonorrhea. We offer to all our patients as the standard of care self-collected specimens for chlamydia and gonorrhea. I'm talking about, someone mentioning the gap of translation between developing of the science and the implementation. I have to say that one of the things that I think can really shorten that gap is when the science, is developed in the places where it's going to be implemented. Evidence of that is Mississippi participated in some of the clinical trials testing nucleus amplification and the use of vaginal swabs in the 2003-2004. And as soon as it became available, it was for environments that typically are very resistant to change. It was something that they quickly embraced. It was something that the health officials were familiar with. And overnight, Mississippi went from doing 25,000, DNA probes in one STD clinic and several, family planning clinics to universal gonorrhea and chlamydia screening, including allowing, self-collection vaginal swabs in women. And to date, and that was the first state in the South that did that. Today, we continue to be the state the state that uses more, vaginal swabs in the country. In part, it was generated because of a need. We don't have enough providers to do pelvic exams, but we didn't want our lack of providers to do pelvic exams prevented our female patients coming to our clinics to be screened for gonorrhea and chlamydia. In our clinics, results are typically communicated via telephone, but we also give individuals the choice to use the patient portal, text messaging. And then under the name of Open Arms, we have since last year started a neighborhood clinic, which is a mobile clinic that basically is stationed in pharmacies in neighborhoods that we know, working with the health department, have high STD morbidity. And it's been a really interesting experience because the literacy level of those individuals who access our mobile clinic is much, much, much lower than of the patients who use our clinic, and reflecting populations that actually really, don't interact with the healthcare system. GC rates are almost double of what we find in our clinic nowadays. STI screening in our clinics, we do STI screening in not only in the clinical spaces, but also we have built collaboration with community-based organizations in other areas of the city of Jackson and Mississippi, in part because in communities that are very stigmatized, especially in the South where homophobia and transphobia are important factors that keep people from accessing services. Community-based organizations that traditionally have done HIV prevention are very often the places that people trust. Even if you may be able to have an STD clinic, in a small rural community, that may not be the place where people may want to go. So we have actually collaborated with these organizations and created a capacity for them to be able to do, to offer, testing, screening of STDs, and then work with them to make sure that they get managed and they get referred to appropriate clinics for treatment. We have experimented, and I say experimented because we haven't totally figured out using the community-embedded DIS. Part is because our first attempt found a number of structural, difficulties and policy difficulties, in the sense that our community DIS hired by us really couldn't access any of the surveillance system with the health department, and while but again the benefit of this is that we really, bring in the DIS from the health department as soon as someone is diagnosed with HIV or syphilis or sometimes with gonorrhea, and we provide assistance to our patients on site, and we encourage them to do the partner notification while they are in the clinic, before they leave the clinic. We encourage them, we emphasize that their treatment is not complete until we're able to complete each one of the sexual partners, recognizing that the chances that they're going to have sex with someone who has sex with those individuals, even if they're not planning to see them again, is actually high. In our clinics, in the testing only clinic as per personal health, we offer same-day prep where there is not a clinician available. So we have a same-day prep protocol that does the HIV test. Based on the HIV negative test, and a medical history that doesn't yield any kind of any suspicion of renal disease, we initiate pre-exposure prophylaxis and then link the individual to a healthcare provider, to a clinician that can do the standard of care within 6 to 12 weeks after the visit. We offer post-exposure prophylaxis and same-day antiretroviral therapy, not because we do the ART right there, but because on the same day people are diagnosed with HIV, we take them to a provider who can provide treatment for HIV. We've been able overall to give access to give people choices of when and how they access sexual health services in a community highly stigmatized and with very high STI rates, but also affected by many other health disparities. We see sexual health as the door of entry and an opportunity to then engage these populations in comprehensive health services so they can live to their fullest healthiest potential. Finally, 2 comments. I think, we have to recognize that we live in a world where treatment of HIV is prevention and where PrEP significantly reduces the risk of HIV infection. So I think that we have to, really spend some time understanding how our patients, our men who assist with men who are disproportionately affected by many STIs, see STIs nowadays. Do they really care? Is this important to them? If it's not, we have to spend time and resources educating this population that STIs are not as trivial as many people may think. And second, I think we have to rethink about which are the effective which are the effective strategies that are going to help us reduce the risk of the rates of STIs in a world where condoms, are not the thing that we need, that people are going to use to prevent HIV infection. So we may think about, perhaps how we, maybe, offer routine screening for STIs, link with partner notification, some kind of supported partner notification, including expedited partner therapy. How perhaps pre- and post-exposure prophylaxis for STIs may have a role. Perhaps vaccine or expedited partner therapy. And second, I think it's important that we reimagine, the journey of people the journey of our patients at different stages of their life, the life course, and create a service delivery system that includes education, that offers quality sexual health services that are convenient, non-stigmatizing, and affordable. And affordable means, for many people, affordable means no pay. We have an opportunity, I think, to promote and implement the comprehensive sexual health services that are needed to achieve the elimination of HIV transmission and to end the current STD epidemic.
Thank you, Dr. Mena.